So why don't we get started, everyone? So once again, my name is Dan. I'm one of the interventional gastroenterologists at Scarborough General Hospital. I'll be chatting about an approach and management to pancreatic cystic lesions. Please feel free to flag me at any point in time if there's any questions, and let me know if you can't hear me or if there's any issues currently. As I mentioned, I'm one of the newer gastroenterologists at Scarborough Health Network. My practice is mainly in pancreatic biliary medicine, particularly with pancreatic cystic lesions, pancreas masses, biliary masses, and interventions associated with those things, including endoscopic ultrasound, ERCP, and everything in between. So before we begin, disclosures for myself include those listed on the slide here. The reason why I wanted to chat about pancreas cysts is that I've noticed that certainly the number of incidentally identified cysts is growing in number, and this is well founded in the literature. So when we look at studies throughout the 2010s into the 2020s, there's an increasing incidence of pancreas cysts that are identified, all comers. So that includes things like pseudocysts, mucinous lesions, and so on and so forth. And that begs the question, how do we actually manage pancreas cysts when we see them on CT or MRI? So if you can see in the slide here, the incidence of incidentally identified cysts can range between 1.2 to almost 50% on MRI. And so I don't think that it's uncommon for us to be seeing these cystic lesions just identified incidentally for whatever reason, whether it's on CT, MRI, or ultrasound. In this particular study, in Northeast Germany, there were 1,077 individuals. The study was aimed basically looking at quantifying disease incidence and prevalence across the board, so not just pancreatic disease or pancreatic cystic disease. All individuals underwent MRI at inception into the trial and then followed prospectively at the 5-year mark and had a subsequent MRI scan, including MRCP. So these were individuals who had an MRI that was targeted toward a pancreas evaluation. There were, as I mentioned, 1,077 participants. The mean age was 55.8. And the prevalence of the cyst was actually quite high at 49.1. So at inception, there were 49.1% of individuals were noted to have pancreas cysts, the incidence of which was 12.9%. So subsequently, in 5 years' time, there was 12.9% more individuals who had developed pancreas cysts in the interim. To contrast that, this study was done in South Korea, around 22,000 individuals, and these individuals just received CT imaging for health screening examination and for no other particular purpose. So patients were asymptomatic once again. Average age of the participants in this study was 58.7 years old, and among them, 457 individuals were found to have a pancreas cyst. So that lands things at around 2.1%, so much lower than the 49.1. The breakdown of the cysts, which I think is important for discussion later in this talk, the majority of the cysts were IPMNs or intrapapillary mucinous neoplasms, followed by indeterminate cysts. So you do all the characterization with CT, MRI, endoscopic ultrasound, and there's still no clear diagnosis, which happens not infrequently. Serous adenomas, comprising 4%, and mucinous cystic neoplasms, which comprise 2% of this population. Overall, in this study, the number of pancreas cysts were far lower compared to the German study just presented. And lastly, I just wanted to show one more study, but this was a Japanese study looking at around 9,000 individuals undergoing abdominal ultrasound, evaluating for IPMN, and also assessing correlates or risk factors or predictors for development of IPMN down the line. So once again, lower incidence or prevalence in this population with 198 patients with IPMNs, or 2.1% of the population. And they noted on univariate analysis that age, body mass index, smoking, hyperlipidemia, hypertension, metabolic syndrome, all of these things were associated with development of IPMN, or predicted incidental finding of IPMN. A multivariate analysis, when they looked at all these variables, the only thing that really predicted development of IPMN was age. So what have I presented so far? Basically, there's sort of variable incidence and prevalence of pancreas cysts that are identified asymptomatically and incidentally, and it may be related to age and certain very common risk factors that we see day to day with our patients. I would say anecdotally, I think we've all seen sort of pancreas cysts or cystic lesions pop up incidentally through imaging scans that are not targeted toward the pancreas. So we see this in ultrasound, CT renal colic protocol. We see this in non-contrast CTs done for whatever reason. And at least in my world, we see a lot of pancreas cysts identified incidentally in our clinic. So how do we manage pancreas cysts? I think at the heart of things, we need to understand what the pancreatic cystic lesion is. So there are cysts that are entirely benign, known as epithelial cysts. These cysts tend to exist in patients with genetic syndromes like von Hippel-Lindau syndrome, adult polycystic kidney disease, cystic fibrosis. And these are cysts that bear no malignant potential, and they're of no consequence except for the fact that patients will develop these cysts. Sometimes they can be symptomatic, but generally speaking, these are benign and don't have a risk toward malignant degeneration, unlike some of the mucinous cysts, which we'll chat about in a second. It is important, however, I would say in individuals with a genetic predisposition to epithelial cysts to still remember that they're allowed to have other forms of cysts that may bear malignant potential and degeneration. Importantly, patients with von Hippel-Lindau syndrome, for example, have a risk toward developing neuroendocrine tumors, and there's a form of neuroendocrine tumors that can be entirely cystic or predominantly cystic in nature. So we'll chat about worrisome features and when to do biopsies and when to evaluate with MRI and endoscopic ultrasound down the road. But bear in mind that just because patients have a predisposition toward benign cysts doesn't mean that they can't develop more concerning cysts in the future. The second type of form of cysts that I think is relevant to us is inflammatory cysts, most notably pseudocysts. And I put that in bold because we'll talk about that in more detail. But inflammatory cysts and things like echinococcus or abscesses that may look cystic are entirely benign, as you might imagine, but sometimes they can fool us. Once again, if there's worrisome features identified in initial CT imaging, whether there's solid components or pancreatic ductal dilatation, then further evaluation needs to be performed. But certainly the epithelial cysts and inflammatory cysts, as you can imagine, are entirely benign and need to be followed somewhat less closely. At the other end of the spectrum, we have solid lesions with cystic components. So we're thinking about things like adenocarcinoma with cystic degeneration, neuroendocrine tumors with cystic degeneration, metastases with cystic degeneration. So these cysts tend to be, these lesions, tend to be more solid in nature and have a minor cystic component. They're usually quite clearly more solid than cystic. The caveat to that is a special type of lesion called a solid pseudopapillary tumor, which is most commonly found in young female individuals, usually in the pancreas tail. These cysts tend to be sort of mixed solid cystic, sort of half and half sort of thing. They have a 10 to 50% risk of malignant degeneration and metastatic disease. And so patients with this particular pathology should undergo resection for that purpose. So age, although being a risk factor for pancreatic cystic lesions, we should be mindful that whenever there's a cyst to evaluate things closely, irrespective of age and sort of underlying risk factors, okay? And lastly, we have the non-mucinous and mucinous neoplasms. So the non-mucinous cystic neoplasms include the serous cyst adenoma, which we'll chat about in more detail. But generally speaking, these cystic lesions tend to look very scary and mass-like and can be a cause for concern when they're initially reported, especially when it comes from a non-contrast or a imaging scan that's not protocolized for the pancreas or the bile ducts. And then last, we've got mucinous cystic neoplasms. Within that category includes IPMNs, which is the most common. There's 3 flavors of that: branch duct / side branch, main duct, and mixed type. That essentially just describes the ductal structure or the ductal anatomy that the mucinous lesion is involving. And we have mucinous cystic neoplasms, which is an entity on its own that has a different type of a risk stratification. So the bolded things from the previous 2 slides, I just want to go into a little bit more detail in terms of their characteristics, what you would find on cyst fluid analysis, and what they look like. So branch duct IPMNs most commonly occur or more commonly occur in female individuals in their 60s and 70s. They tend to be small. Patients tend to be asymptomatic. They tend to be grape-like, so they can be multicystic. They can be multifocal, and they can involve the main pancreatic duct and cause pancreatic ductal dilatation. So they are contiguous to the main pancreatic duct, which is a hallmark feature of IPMNs. In contrast with mucinous cystic neoplasms or MCNs, this is predominantly greater than 95% of the time arising in females in their 40s and 50s, predominantly in the body and tail. They tend to be larger when they are identified. They tend not to involve the main pancreatic duct, and they tend not to be contiguous to the main pancreatic duct. So that 20%, I don't think that I've seen a mucinous cystic neoplasm actually be contiguous with the main pancreatic duct, and that's sort of evidenced by the cyst fluid analysis as well, by the low amylase that we see with MCNs. But generally speaking, if lesions become large enough, they're compressing the main pancreatic duct or the bile duct, they can cause things like obstruction and upstream pancreatic ductal dilatation. Proof at the end of the day for something like this is in the biopsy and FNA, FNB. The next column is serocyst adenomas. So once again, female predominant, occurring in the 60s and 70s. Generally speaking, patients are asymptomatic. There's 3 flavors of serocyst adenomas. Patients can either have microcystic disease, meaning small cysts that almost look solid because they're so small. Macrocystic or oligocystic, meaning that there's a couple of large cystic components and then a mixed component. One of the possible hallmark features of a serocyst adenoma is the central scar. These lesions, once again, don't tend to be involving the main pancreatic duct, but if they're in an opportune location, they can cause compression and upstream dilatation. And once again, not classically involving the main pancreatic duct. And lastly, we've got the pseudocysts. It mentions that it's mostly a male predominant feature, but it obviously can happen with anyone who's had pancreatitis, usually occurring in the 4th and 5th decade. Location-wise, predominantly in the body and tail, unilocular without complexity. And then they make a note, and I think this is a good note with regards to irregularity of the main pancreas duct, which may be a result of ductal disruption or chronic pancreatitis when there's lithiasis within the pancreas duct. When you look at the last row, there's a row about cyst fluid analysis, and this is sort of important in my world, but this helps us to more confidently delineate what the origin of the cyst is, and as a result, what their malignant potential is and how we should survey these cysts moving forward. For mucinous lesions, particularly IPMNs, they're mucinous, which we can identify via a particular technique called a string sign, or we can see that under pathology. Their cyst fluid analysis has high CEA, high amylase as it's contiguous to the main pancreatic duct. And in next generation sequencing, they have mutated KRAS and GNAS. Whereas for mucinous cystic neoplasms, it's mucinous with a high CEA and a low amylase because they tend not to be contiguous with the main pancreatic duct. KRAS is mutated, but GNAS is wild in this particular case, so we can differentiate between an IPMN and an MCN on those grounds. Serocyst adenomas are serous lesions, so there's no mucin that's identified. Basically, your KRAS and GNAS mutations are wild, and basically the CEA and amylase are low. As you can imagine, with a pseudocyst, it's sort of the opposite of an MCN, where you have a very high amylase because it's related to ductal disruption, but the CEA, generally speaking, is within normal limits, and it's a non-mucinous lesion. So let's unpack these lesions, or these common lesions, one by one, because I think that's most relevant to us within medicine. So I know that Dr. Chan did a grand rounds presentation on pancreatitis and peripancreatic fluid collections and management of these things, but I do think it's important just to go over this briefly, because it's important for us to operationalize what a pseudocyst is, what a walled-off necrosis is. That allows us to do research and to better understand how to actually treat patients and whether or not they're candidates for cystic decompression. So first of all, there's two flavors of pancreatitis. First form is interstitial edematous pancreatitis, and the second is necrotizing pancreatitis on the right. Generally speaking, interstitial edematous pancreatitis is uncomplicated, while necrotizing pancreatitis bears more complications. At the outset, when you get an MRI or CT scan, you might see hypodensities within the pancreas in necrotizing pancreatitis, which is suggestive of necrosis. And that leads you down two sort of pathways. So with acute interstitial edematous pancreatitis, patients within 4 weeks will, if they have fluid around the pancreas, will develop an acute peripancreatic fluid collection operationally, and then subsequently develop a pseudocyst. That's important because a pseudocyst is defined as a well-encapsulated, well-mature cystic lesion, whereas an acute peripancreatic fluid collection is not. And so doing a procedure for cystic decompression of a pseudocyst is appropriate, but it's very not appropriate for a undefined peripancreatic fluid collection. On the other hand, we've got necrotizing pancreatitis, where within 4 weeks, one will have an acute necrotic collection, which can change into a walled-off necrosis. But this talk is mainly about cystic lesions, so we're going to focus on the pseudocyst discussion. So once again, pseudocysts are encapsulated, mature fluid collection secondary to pancreatitis, and importantly, pancreatic ductal disruption. In terms of my approach to pseudocyst management, number one is serial CT imaging to ensure that there's improvement or stability down the line in a number of months when they're out of their acute episode. But also CT imaging or MR imaging can be helpful to assess for things like an occult lesion that may have stemmed or contributed to pancreatitis, like an IPMN, for example, and or ductal integrity. So as I just mentioned, generally speaking, pseudocysts occur because of ductal disruption. And as a result, if there's a disconnected duct syndrome, the management plan tends to be a little bit different in terms of managing pseudocysts. Now, as I mentioned at the beginning of this chat, generally speaking, EUS would be considered for atypical features or concerning features, which we'll go through in the talk. But generally speaking, that would include things like suspected solid components or a dilated pancreas duct or pancreatic atrophy, so on and so forth. So what are our indications for endoscopic decompression? Because we get asked this question a lot about what we do about quote unquote pseudocysts or acute peripancreatic fluid collections. Well, number one, if there's an infected peripancreatic fluid collection, that's a great indication to put a drain in place, either percutaneously or endoscopically. And secondly, if there's signs and symptoms of outlet obstruction, notably things like nausea, vomiting, poor appetite, so on and so forth. It's important to note in the context of pancreatitis, patients can have a lot of nonspecific gastrointestinal symptoms that can develop gastroparesis, ileus, ulceration, so on and so forth. So it's critical to establish a diagnosis of gastric outlet obstruction prior to putting in a large drain, because it is fraught with some amount of risk despite its perceived benefits. How do we drain cysts internally? Well, there's two flavors. One is via a lumen-opposing metal stent, which is a large dumbbell-shaped stent, and the other is through plastic stents. Previously, I think some of our more senior colleagues with therapeutic endoscopy training who were not trained in endoscopic ultrasound would look at a gastric impression of where the pseudocyst might be and blindly access the area with a cutting instrument and put stents in place. We've somewhat evolved, I think, from that reality by use of endoscopic ultrasound. So we're able to clearly visualize where the cyst is. the surrounding vascular structures, make a puncture, and place the stents in. Now, this is a bit of an important slide, I would say, because at least from a technical perspective, from a gastroenterology perspective, because lumen-opposing metal stents, they're much easier to deploy. It's a one-step device, but they cost around $6,000 compared to plastic stents, where the cost is probably in the order of a couple $100. So it's several-fold more expensive using a lumen-opposing metal stent for pseudocyst drainage. Lumen-opposing metal stents, as I mentioned, are 20 millimeters in diameter, so they're much larger. We can drive a camera in through there and clean up any sort of necrotic debris that might exist. It's not possible with plastic stents. Procedurally, with plastic stents, we would have to access the cyst with a needle first, stick a wire in place, dilate the tract, and then place usually 2 stents via the stomach or the duodenum into the tract under fluoroscopic guidance. So it's much more involved just from the description of things. In any case, when we evaluate the use of large metal stents versus double pigtail plastic stents, in this study done at McGill and Hopkins, 205 individuals were recruited into the trial, head-to-head looking at lumen-opposing metal stents versus plastic stents. Technical success was similar. However, clinical success was higher with lumen-opposing metal stents. It's probably because of the larger caliber stent being 20 millimeters in size compared to the conventional size of plastic stents, which is around 10 French or 3.3 millimeters in diameter. There's a lower recurrence rate. You can imagine if there's any sort of necrotic debris inside the pseudocyst cavity itself or the wall-duct necrosis, that's less likely to cause occlusion. And lastly, there's a higher rate of adverse events with double pigtail plastic stents. So just going through the procedure itself, you can understand that at any step of the way, some of these things can go wrong at the outset, and at the same time, it can cause issues with regards to stent occlusion, migration, and so on and so forth because of the caliber of the stents themselves. So the gastroenterology community, when we drain pseudocysts, largely speaking, the preference is to use a large metal stent that is more expensive, but I would argue has greater clinical success and fewer adverse events compared to the alternative. Now, with this question with regards to this operationalized definition of a pseudocyst or a wall-duct collection occurring at the 4-week mark, at the end of the day, this is somewhat of an important question. As we've seen with some of our patients in the medicine ward, if we decline them for endoscopic drainage and these patients end up getting a percutaneous drain during an acute pancreatitis bout with peripancreatic fluid collection, they can develop pancreatic fistulae to the skin. And so that can be very, very hard to treat. You can imagine that's certainly very, very common when percutaneous drains go in place for these individuals with the inflammatory milieu. This meta-analysis looked at 6 studies, 630 patients, around equal collection size. Technical success was similar in individuals randomized to drainage less than 4 weeks versus greater than 4 weeks. No benefit of clinical success between the two. No overall adverse events, no significant signal in terms of mortality. There was a signal toward a longer hospital stay for individuals undergoing early drainage compared to standard drainage or greater than 4 weeks. I bring up this slide because it's important to recognize that just because patients have a fluid collection that's been in place for less than 4 weeks, it doesn't mean that it's not drainable. In my mind, the most important thing is that there's actually a well-defined wall surrounding the cyst that would allow for safe drainage to occur. So I think the right answer here in terms of when to drain cysts is whether there's an indication, and 2, whether there's a well-defined wall that will allow for safe drainage to occur. So please, 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 if there's any concern about an infected pseudocyst or any need for endoscopic drainage, please reach out to myself, Dr. Chan, and anyone else who does this particular procedure, because we'll review the images. Generally speaking, we'll chat with hepatobiliary surgeons in terms of finding the best approach to dealing with these things, and we'll take care of this. So feel free to reach out from this regard. So I just wanted to illustrate one case that was done locally here at Scarborough, as you can see just on the right-hand side. And I should just backtrack a little bit by saying that this was a young 30-year-old female who had pancreatitis and a large peripancreatic fluid collection and pseudocysts, highly symptomatic with outlet symptoms, nausea, vomiting, early satiety, losing weight. On the right-hand side, you can see a large impression on the stomach. And so that is where presumptively the pseudocyst is. Presumptively, before EUS was available, the practitioners would stick a cutting instrument into this area somewhat blindly and hope that they gained access into the perigastric collection. On the left-hand side, you can see the CT scan. There's a very large, sort of football-sized collection in the center of the abdomen. And just to the left of it is the duodenum. So it's entirely compressed. So although the gastric lumen appears patent, that's clearly not the case here on CT imaging. So this is some images of endoscopic ultrasound. If I can convince you, on the left-hand side, there's a very, very dark, sort of cystic appearing lesion almost occupying the entire screen. And around that, there's a hyperechoic or bright rind, so a well-defined collection. And then just on the bottom right-hand side of the left image, you can see that there is some hyperechoic density there, which is most likely necrosis. So on the right-hand side, this is myself and Dr. Chan putting a lumen-opposing metal stent in via endoscopic ultrasound. So we're able to see all the vasculature. We're able to do this very safely. And after successful deployment, you can see on the left-hand side that there's fluid on both sides of the stent, meaning that fluid is draining nicely from the peripancreatic fluid collection into the gastric lumen. And if I might convince you on the endoscopic images, it looks like that big mound that was once present is no longer there, or it's decompressed significantly. So in subsequent weeks, myself and Dr. Chan, we did a little bit of cleanup with the necrotic debris inside the cavity. So we're able to drive our camera into the cyst cavity itself. We debrided this with a snare and baskets and other devices. And on the right-hand side is sort of the finished job for after debridement. And we've since removed this stent. This patient's doing great. She hasn't had any recurrent symptoms. And she's done very well with this approach to her pseudocyst. The next type of cystic lesion I want to chat about is serous cyst adenoma. So as I mentioned, they can look very scary. They can look very mass-like if they're not protocolized correctly with the CT pancreas or MR pancreas. On the right-hand side, you can see a very large mass-like circular shaped mass. Generally speaking, these tend to be well-defined lesions, unlike pancreas adenocarcinoma, where they tend to be very ill-defined. As I mentioned, they come in 3 flavors. Microcystic, which is the most common form, where you get these very small sort of honeycomb-like cystic compartments. And as a result of this being a very small multicystic compacted lesion, it can look solid. It can be oligocystic or macrocystic, or it can be mixed. So it can have both components of oligocystic, serous adenoma, and microcystic. Now, the risk of malignant degeneration is cited to be as low as 0.1%. So if you've got the diagnosis clearly that this is a serous adenoma, you probably don't need to follow these. However, once again, if there's any worrisome features, lesions need to be further evaluated with endoscopic ultrasound. So once again, worrisome features is large cyst, pancreatic ductal dilatation, pancreas atrophy, so on and so forth. And there'll be a table later on for your reference. So my approach to serous adenoma, so once again, no need to survey the patients if a diagnosis is clearly established, conservative management and expectant management. So sometimes these cysts get so large that they can cause symptoms and biliary obstruction. ERCP is reasonable at that point in time. If they're young, healthy, and fit, and they're highly symptomatic, outlet obstruction, biliary obstruction, pancreatic ductal dilatation and obstruction, surgical intervention is not unreasonable as well for refractory symptoms and obstructive symptoms as well. Lastly, I want to chat about the meat of this discussion, which is regarding mucinous lesions, particularly intraductal papillary neoplasms, because this is the thing that sort of comes up most commonly in reports, in CT reports and MR reports. There's three flavors, as I mentioned previously: main duct IPMNs, branch duct IPMNs, and mixed type IPMNs. Main duct IPMNs bear a very, very high risk of high-grade dysplasia and invasive carcinoma, although you can see the range is quite variable, from 11 to 81% for invasive carcinoma. Generally speaking, the classic teaching for any sort of main duct IPMN is referral to hepatobiliary surgery and consideration of surgical resection. Contrasting that is branch duct or side branch IPMNs. So they bear a much lower risk of high-grade dysplasia and invasive carcinoma with a varied range. As you can see, the numbers, you can think to yourself, 15 to 48 and 6 to 38% are pretty high for sort of advanced neoplasia. Should we be removing all of these branch duct IPMNs that we see and that are found incidentally on CT or MRI? This particular study, I should mention, looked at resection specimens. So these patients with branch duct and side branch IPMNs with high-grade dysplasia and invasive carcinoma, they actually had worrisome or high-risk features. So they had a solid component or ductal dilatation. There was something very worrisome about their appearance. And as a result, the actual risk of malignant degeneration of branch duct IPMNs is actually far lower, which we'll present in a couple of slides. Lastly, you've got the mixed type or mixed flavor of IPMNs. I find that this is actually a very difficult diagnosis to make, because patients, when they have significant main duct IPMNs with all the mucin within the main duct, can cause dilatation of the side branches of the branch duct, and it can look like a mixed type IPMN. Whereas with a branch duct IPMN, as you'll begin to know later, or probably already know, once they become more significant with worrisome features, they can cause main ductal dilatation as well. So it makes this diagnosis of a mixed type IPMN actually quite challenging. And so my approach with mixed type IPMNs and the classic teaching has been always to treat mixed type IPMNs as a main duct IPMN. So treat it as a high risk lesion that might require HPB consultation and resection. So just to give you a sense of what these lesions look like, if you can look on the left-hand side for branch duct IPMNs, the sort of ductal structure you can see off to the right-hand side as the pancreas duct. If I can convince you, you can sort of follow it. It's very normal. It's smooth. It sort of dives down. It meets the bile duct at the ampulla. And while it dives down, there's a large cystic lesion. Clearly, that is not involving the main pancreas duct. It's involving just the side branch. So the main duct is not involved there. Whereas in the middle, you've got a main duct IPMN. You can see the ductal structure is entirely dilated throughout. And then lastly, you've got the mixed type IPMN, where you've got a dilated side branch. So that sort of larger cystic lesion below the pancreas duct is quite dilated. And then you've got the rest of the pancreas duct, which is dilated as well. So once again, a little bit difficult to make a diagnosis of a mixed type IPMN. Does it actually represent a main duct IPMN with significant mucin deposition within the main duct, or is it a branch duct IPMN that's degenerating into adenocarcinoma or high-grade dysplasia? Difficult to entirely know until patients undergo resection. So I'm going to present a couple of studies that look at the risk of IPMNs. As I mentioned, in resection specimens, the numbers are quite high, upwards to 30 or 40%. They would have high-grade dysplasia or advanced neoplasia or invasive carcinoma. This study in Japan looked at 1,400 individuals with 9,000 person years of follow-up. 68 individuals developed pancreas adenocarcinoma. And the overall incidence of pancreas adenocarcinoma for all branch duct IPMNs of all flavors of varying sizes and worrisome features at 5, 10, and 15 years was 3, 6, and 15%. So not low when you look at this particular study. In contrast to this, when you look at this study done, I believe, in China or Korea, This looked at 3,800 individuals with IPMN, most of which were branch IPMNs. Average follow-up was 84 months. And they noticed that only 4% of individuals developed pancreas adenocarcinoma out of this group. So significantly lower, although the follow-up period is not as robust as the prior study. It did, however, note that in the subgroup analysis that cysts less than 20 millimeters in size without any worrisome features or interval growth in 5 years didn't show any malignant conversion whatsoever. So what is our goal with IPMNs? Unlike pseudocysts or serocystic adenomas, our goal for IPMNs is to survey these cysts, and once they develop worrisome features, refer them for resection to prevent degeneration of adenocarcinoma. So what are these high risk and worrisome features that I keep alluding to? Well, there's been a number of studies looking at high-risk features for adenocarcinoma or advanced neoplasia, including things like obstructive jaundice, an enhancing mural nodule or solid component, a significant pancreatic ductal dilatation greater than 10 millimeters, and suspicious or positive cytology results on EUS, FNA, FNB. So you can see the sensitivity and specificity of these things are moderate, but when you have multiple of these factors, it sort of cements that diagnosis that it's something more worrisome and needs to come out via surgical resection rather than a watch and wait approach. At the same time, there's worrisome features, so features that are concerning, but not so concerning as the high-risk features, including things like acute pancreatitis, new or worsening diabetes, wall thickening identified on EUS or imaging, cyst size greater than 30 millimeters, enhancing mural nodules or solid components less than 5 millimeters, ductal dilatation, abrupt pancreatic ductal caliber change with upstream pancreatic atrophy, and an accelerated rate of growth for cysts. So as I mentioned, when you think about pancreatic cystic lesions, we just be mindful of what some of these worrisome features and high-risk features are that have been studied in IPMNs. Most likely, you can apply these worrisome features to all your other cysts. So do you have a large cyst that's greater than 30 millimeters? You should probably have a closer look and watch things more closely than someone with VHL with a multiple subcentimeter cysts through the pancreas. That's less worrisome, right? So just this slide in the past and the prior slide are important. Just remember these things as important features. In a nutshell, once again, that's jaundice, mural nodularity, or a solid component, a clear solid component, pancreatic ductal dilatation, and pancreas atrophy. Those are the things that you should remember for worrisome features of all comers. Now, these guidelines for IPMN surveillance, they've been recently discussed and sort of revised in 2024 in Kyoto. The last iteration before this was in 2017, so this is a pretty big update after consolidation of all the evidence. If you can just go from the top of the slide to the bottom, you can see that any individuals with a high-risk stigmata, obstructive jaundice, enhancing mural nodularity, main pancreatic ductal dilatation, refer them straight for surgical assessment with HPB. EUS can be used for further characterization of the lesion itself. Whether to biopsy or not to biopsy is a discussion to be had with the hepatobiliary surgeons. If patients don't have any high-risk stigmata of high-grade dysplasia or invasive carcinoma, if they have any of these worrisome features, it depends on how many they have and how worrisome the lesion looks like. So if you look at the middle box where it asks, are any of the factors present? Repeated acute pancreatitis, multiple worrisome features augmenting the likelihood of high-grade dysplasia or invasive carcinoma, and they're young and fit for surgery, refer them for hepatobiliary assessment, review with your hepatobiliary surgeons, refer to for endoscopic ultrasound for further characterization, and we'll discuss with hepatobiliary surgery in terms of the appropriateness of biopsying the lesions. If not, and the lesions are not complex, then we would start them on a surveillance plan. So if they're less than 20 millimeters, the new consensus guidelines would say do high quality imaging in 6 months. And if it's stable, every 8 months, and if stable thereafter, stop after 5 years. Whereas if there's any interval growth or if they're larger than 20 millimeters, then you can see that we would survey these patients a little bit more aggressively depending on their size. But once they develop worrisome features, doing the EUS is entirely reasonable. Referring to hepatobiliary surgery is entirely reasonable. And the question of whether to biopsy the lesion or not is a discussion between the endoscopist and hepatobiliary surgeon, depending on whether or not it would change management for the patients moving forward. So as I mentioned, the prior iteration of these pancreatic cystic lesion management was the Fukuoka criteria. The only thing I want to mention is that it was probably a little bit more granular, but somewhat more confusing about how to screen these lesions. And this particular guideline was for diagnostic endoscopic ultrasound. So look, but don't biopsy. And the reason why for not biopsying or not doing an FNA, FNB was the risk of seeding. If it was a high-grade lesion or invasive carcinoma, there have been reports up to 2.5% of the time that there's peritoneal seeding that might change or alter, obviously, a patient's course. I think more and more evidence has demonstrated that's less of a concern. And generally speaking, if you need to know what things are, doing a biopsy for prognostication and diagnostic clarification is reasonable, obviously after discussions with your hepatobiliary colleagues. So what is the role of endoscopic ultrasound in all of this? So I'm a little bit short in time, so I'll try to blast through these slides, but generally speaking, endoscopic ultrasound can be used to confirm mucinous nature. So if you remember from one of the first slides, mucinous cystic neoplasms and IPMNs, they have an elevated CEA. And so a meta-analysis evaluating CEA, 15 articles demonstrate that at a cutoff at 192, there's actually quite good specificity in terms of ascertaining a mucinous nature of the cyst. Sensitivity not so great at around 60.4%. We can confirm mucinous nature via intracystic glucose levels. So there's more and more studies demonstrating that if we collect glucose from the cyst itself, there's high sensitivity and specificity for ruling in and ruling out cystic lesions. I've adopted this in my practice because it's no different from what we would usually do for a EUS, FNA, and cyst fluid aspiration. Obviously, it can confirm disease and neoplasia with cytology. So in that action of removing cyst fluid for evaluation, we can send it off to cytology. Generally speaking, specificity is quite generous at 88%, but the sensitivity, once again, is sort of mild to moderate at 0.63. This has been very well studied in meta-analyses throughout our space. So how do we do endoscopic ultrasound? How do we find these cysts? So generally speaking, once we have a high quality MRI or CT scan, we correlate that area endoscopic ultrasound, try to find the area of interest, measure things out, assess whether or not it's contiguous with the pancreas duct if we can, see if there's any concerning components like thickened walls and solid components and pancreatic ductal dilatation. And then if I can convince you on the right-hand side, we're using Doppler there to see if there's any intervening vessels. We stick a needle into the cyst itself. This picture actually demonstrates that the needle tip is inside the cyst, and then we start aspirating from the cyst itself with negative pressure with a suction device. And we essentially collect all the cyst fluid until there's full collapse. I usually biopsy the cyst wall as well for what it's worth. And generally speaking, we would send all the studies for biochemistry. So my usual practice is to send everything that we mentioned, including CEA, cytology, glucose, and also amylase, because that will tell you whether or not it's a pseudocyst or whether it's IPMN or MCM. So what are some other things we can do with endoscopic ultrasound? Well, when I was doing my fellowship in the US, the group would routinely send all the cyst fluid for KRAS and GNAS. And as you might remember at the beginning of the presentation, KRAS and GNAS are found, both mutations are found in IPMNs, but not so in MCNs. And so it may provide some more targeted therapy in terms of what the lesion is and how to treat the lesion. And it's got very high sensitivity and specificity borne out in multiple meta-analyses and studies The problem with doing next generation sequencing is that it's expensive. So it costs around $750 American to $1,500 American to run these specific mutations for pancreas cysts. So I'm not sure that this has made prime time yet in terms of our practice. It's only mainly for sort of trial-based patients that we would do this on occasion. There's also through the needle microbiopsy forceps. So in the center there, that red thing is a cyst. Basically, there's we would do the regular endoscopic ultrasound with an FNA needle, and through the FNA needle itself, we'll put a microbiopsy forceps through. The diameter of the FNA needle is around 1 millimeter in size, and so it's truly a microbiopsy forceps. And basically, you would take tissue from the edge or the wall of the cyst and or any solid components that might exist. Technical success is quite good in this case, meaning that you're actually able to put the needle through the EUS FNA needle. Tissue acquisition, meaning actually seeing macroscopic amounts of tissue, was reasonable, but the diagnostic accuracy was sort of mild to moderate at 68.6%. So despite having good tissue or sufficient tissue from the biopsies, was not always so easy to make a firm diagnosis of whether or not this was an IPMN or cystic or another cystic lesion. Adverse events doing this particular procedure are high. 10% can have pancreatitis, as you can imagine. You're irritating something around the pancreas, or intracystic bleeding as you're biopsying a paper-thin cyst wall. Another technique that's been described is using confocal endomicroscopy to improve diagnostic yield. So basically similar approach, you'd use an FNA needle and then use a microscope essentially, or an endomicroscope to evaluate the cyst wall. You can see the measurements on these images are 20 micrometers, so very, very small. And if you can believe with the eye of faith, on the left-hand side is a serous cyst adenoma, and on the right-hand side is an IPMN. Obviously, one of the drawbacks to this is that it's highly expensive to run a program that would allow you to do something like this. And secondly, it's very expertise laden as well. Like it's very, very difficult to ascertain, 100 shades of gray and whether or not this is an IPMN versus a serous cyst adenoma. You're probably better served using high quality imaging and conventional EUS with that diagnosis, to be entirely honest. But under capable hands, meta-analyses have demonstrated quite reasonable sensitivity and specificity using some of these adjunct techniques in the 85 to 90% range. And then lastly, from the EUS front, we can use EUS guided ablation techniques. So we do this routinely or not infrequently for celiac axis neurolysis for pancreas cancer, but you would inject ethanol or a combination of ethanol or a caustic agent and or burn via RFA for high-risk pancreatic cystic lesions. A complete resolution of the cyst is mild to moderate, 44%. Partial cyst resolution, not great at 30%. And once again, the adverse event rate is quite high at close to 15%. With pancreatitis, bleeding, so on and so forth. Just remember that whenever you stick a needle into the pancreas or burn the pancreas or do anything crazy to the pancreas is going to respond in some way, shape, or form that is unfavorable for the most part. In terms of the role of ERCP or ERP in this particular case, certain groups have looked at sticking a cannula into the pancreas duct and taking their fluid for cytology and seeing whether or not there's any added benefit in patients with pre-existing worrisome features. So someone with a muronodularity or dilated pancreas duct, if you did an ERP, cannulated and then sucked out the fluid, does that increase the yield of diagnostic clarification? With worrisome features, so sort of concerning features, but not sort of slam dunk, it increased the yield of diagnosis from 33.1 to 48.8. But when patients already had high-risk stigmata, so meaning things like biliary obstruction and so on and so forth, analyzing pancreas fluid in addition to those high-risk features really did not add much. Once again, as I mentioned, sticking a scope into the pancreas duct, not a good idea. Risk of pancreatitis in a case like this is around 25%. Lastly, one can use pancreatoscopy to directly visualize and sample the suspected IPMN. So aside from doing an ERP, which is cannulating the pancreas duct and sucking fluid out with a cannula, you can actually put a camera inside and evaluate the pancreas duct, take targeted biopsies of any sort of papillary lesions, suck out the fluid, and so on and so forth. Technical success is generally quite reasonable in this case. Visualization can be sometimes challenging depending on the burden of mucin. And the biopsy sensitivities and specificities are sort of all over the map because utilizing a small camera within another camera, so doing a pancreatoscopy procedure, it can be sometimes very difficult to control where the biopsy forceps are actually coming out. Once again, adverse event rate, specifically pancreatitis, is in the ballpark of 12%. So doing some of these procedures, especially ERP or pancreatoscopy with ERCP, high risk of complications. So this is just an image of, on the left-hand side, an ERP or endoscopic retrograde pancreatography. So you can see the wire going toward the spine or toward the pancreas, and then limited injection demonstrating a tortuous pancreas duct. And then on the right-hand side, that's pancreatoscopy. So that's a scope within the pancreas duct itself. You can see that there's a lot of papillary, there's a papillary lesion there that could render itself for biopsy with pancreatoscopy. So quickly, what's my approach to pancreatic cystic lesions? First of all, get a high-quality MR pancreas or CT pancreas protocol. As I mentioned, a CT renal colic or an ultrasound really is not sufficient to characterize pancreatic cystic lesions. Get your usual pancreatic biliary enzymes, amylase, lipase, CA19-9. If there is any concern that it's not a pseudocyst or a serous adenoma, your decision to survey these patients depends on their clinical status and their value preferences. So a moribund 90-year-old individual with a IPMN, have a thoughtful discussion with family, but generally speaking, these are individuals that you probably should not survey because the common endpoint, which is surgical resection, is probably not a option for these individuals. So for pseudocysts and serous adenomas, I would encourage at least one subsequent image so there's no interval concerning features. EUS if there's any worrisome features, therapeutic EUS for symptomatic disease, so your pseudocyst or gastric outlet obstruction, and then therapeutic ERCP for symptomatic disease, including biliary obstruction. For mucinous lesions, if there's a main duct, send it to hepatobiliary surgery, send it to us. We'll discuss with hepatobiliary surgery with regards to EUS plus minus biopsy, or whether they just want us to have a look. If it's a mixed type IPMN, once again, treat it as a main duct IPMN or a branch duct with worrisome features, send it to hepatobiliary surgery, send it to us. We'll discuss with hepatobiliary surgery regarding an EUS plan. And lastly, for branch duct IPMNs and MCNs, if there's no worrisome features, no high-risk stigmata, survey these individuals like you would under the Kyoto criteria, meaning serial surveillance depending on size. If there's any current or interval development of worrisome features, neuronodularity, masses, pancreatic duct dilatation, send to us once again for EUS, and then we'll discuss with our hepatobiliary surgeons whether or not they'd like us to collect cyst fluid analysis and or to target biopsies of the cyst itself. But generally speaking, the workflow for a pancreatic cystic lesion that's favored to be an IPMN is a discussion with us for endoscopic ultrasound and a discussion with hepatobiliary surgery. The reason why we don't want to biopsy things or irritate the pancreas or inject or biopsy the pancreas or the surrounding pancreas is if they're a surgical candidate, causing pancreatitis may, one, cause severe pancreatitis with disastrous outcomes. And the other is that you might set their plan back from a surgical perspective for resection. So lastly, my last slide, my thoughts with EUS right now is it's mainly used for cyst fluid analysis and characterization of the cyst itself. Those other cool things that we discussed briefly, including the endomicroscopy, NGS, through the needle biopsy forceps, pancreatoscopy, ablation, they're fraught somewhat with complications. They might be very expertise laden, and sometimes the cost of these things are inordinate that would not allow us to really run a program with something like that in mind or in place. Thank you so much for everyone's time. Are there any questions at this point? If there's any questions in the future with regards to pancreas cysts or any sort of pancreatic biliary issues, feel free to reach out. You can find me on Epic Chat or via email. I'm happy to review cases as a curbside or a formal consultation. But otherwise, thanks for everyone's time.